In this recent study, using the Advanced Diabetes Prevention and Management Panel, as we were developing this panel, we studied over 6,000 patients. Of those patients, 2,761 were fasting. Of those fasting patients that we evaluated for insulin resistance, it turns out that if you use the standard of care model looking at glucose and hemoglobin A1C, we were able to pick up about 54% of the patients who were truly insulin resistant. If you used the advanced panel, the advanced biomarkers, we were able to pick up 82% of the patients that were insulin resistant. And thus there was 28% of these patients that were insulin resistant that would have been missed if all you used was the standard of care model. In this advanced panel, we developed 3 areas of concern. The top area being that of glycemic control, the middle section being of insulin resistance, and the third section being beta cell function. These particular areas are key, and I would add one more area of importance, and that's the inflammatory response. If you look at that top section and you want to know how your patients are doing at various intervals with glycemic control, you're also going to know how they're doing with diet management of food. If the person is overeating carbs at the 12-week interval measured by the hemoglobin A1C, you'll see a shift of one going to a higher level from the previous test to the present test. Fructosamine picks up the blood glucose control over a 6-week period, and your blood glucose control over a 2-week period would be that of the postprandial glucose index. The glycation cap would be somewhere in between that, the 3 or 4 week level. That being said, you can watch to see how your patient is not only controlling sugar but also controlling their diet at particular periods. It's not unusual for a patient to actually get their blood drawn, overeat carbs for several weeks, thinking the physician or clinician would not be able to detect it at that particular time period, clean up their diet in the last 6 to 8 weeks prior to their next blood draw, thinking that no one would know it. But with this type testing, you would see that and be able to call the patient and keep them accountable. The second section is maybe one of the best group of test panel biomarkers looking at insulin resistance. You have everything from brain insulin resistance being picked up by the leptin to BMI ratio. You have fat cell inflammation being picked up by adiponectin levels. And then you have these 3 new extremely sensitive biomarkers for insulin resistance: alpha hydroxybutyrate, the oleic acid, and the linoleucel GPC. This bottom section here is looking very closely at how the pancreas is handling the workload. And if there's pancreatic inflammation, you certainly need to look at the possibility of using insulin in these patients to take off workload from this pancreas. The last test on this panel is that anti-GAD antibody or autoantibody, and you now have a ability to see which of your patients are developing LADA, or type 1.5 diabetes. Type 1.5 diabetes is this autoimmune response that's occurring over a 5 to 8 year period, destroying the pancreas, which differentiates it from the younger patient that might be having a positive anti-GAD antibody but losing or destroying the pancreatic beta cell function over a 3 to 6 month period. That would be a type 1 diabetic, while this type 1.5 is very slowly losing pancreatic beta cell function. If you take these patients and this advanced diabetic panel and add a 2-hour glucose tolerance test, you can see additional information. For instance, this patient has a 5.8 hemoglobin A1C, which by definition would place this patient in impaired glucose tolerance. But if you look at that 2-hour glucose test, the 2-hour glucose was 194, which is so close to 200 you would be hard-filled not to call this patient a true type 2 diabetic. If you look at this patient and the area of glycemic control, it's also a model that explains what I said earlier about seeing what a patient did after the last blood draw. Look at the hemoglobin A1C that went from 5.1 to 5.7. This patient, after the blood was drawn, overate carbs. You can see it extends on into the fructosamine. So for 6 weeks after this patient's blood was drawn, this patient had a worsened level of carbohydrate control and was eating way too many carbs for the body to process. You can see the minus 1.76 on the glycation cap. That would suggest that this patient cleaned up the diet closer to the time to get the blood drawn, but couldn't do it completely, as seen by the postprandial glucose index. This patient had 2 to 3 fairly bad episodes of glucose intake prior to the next blood draw. Thus, now you can describe to the patient what you see he or she has done after the last blood test. And once you begin explaining these things to patients, they realize they can't eat in the closet. A patient that knows they can't eat in the closet will tend to do better because they don't want to disappoint the clinician, and they also want to be perceived as doing their very best in controlling this disease state. If you look at the next section having to do with insulin resistance, in this particular case, you see the leptin to BMI elevation that's reflective of the fat cells sending a hormone to the brain in the area of the hypothalamus to downregulate the appetite. When the brain doesn't get the message, it sends a higher and higher and higher level of leptin until eventually the brain understands there's too many carbs involved in the patient's food intake, and they need to slow down on food intake, slow down on carb intake. But in this particular case, because the patient is leptin resistant, you see an elevation. Now, when you see leptin resistance, I personally believe that's reflective of a patient who's developing insulin resistance in the brain. That's going to be the patient who is a type 3 diabetic in the making, and thus a person that's at risk of developing Alzheimer's syndrome. In 2005, Brown University has done a study that suggested that the 3 parts of the brain, the frontal cortex, the hypothalamus, and the hippocampus, were shown in pathology specimens, autopsy, to have lower levels of glucose within these areas of brain tissue and lower levels of insulin growth factor. If you went next door into the area of the cerebellum, there was actually no reduction in glucose, no reduction in insulin growth factor. So this was a specific targeted area of insulin resistance in the brain that also would tie in with leptin resistance, which would also tie in with the risk of developing Alzheimer's syndrome. Now, where that will become important is if you, as a clinician, are doing advanced testing, you can now recognize who is at risk of developing this process of Alzheimer's and get this patient on an pioglitazone or Actos to downregulate the insulin resistance in the brain as well as the insulin resistance in the body. And you can begin using a GLP-1 analog like Byetta, Bydureon, and Victoza, Tansium, in a way that would actually improve the beta cell function and hopefully downregulate this response and stop this patient theoretically from becoming an Alzheimer's patient, stop this patient from having worsening brain issues because of insulin resistance. You see these other levels tied in with type 2 diabetes insulin resistance, and thus you have many ways of measuring what's very important to this patient, because the earlier you pick up on insulin resistance, the more likely you're going to succeed in turning this disease state off in an easier fashion. I think these 3 biomarkers, the alpha hydroxybutyrate, the oleic acid, and the linoleal-GPC, are going to be major game changers in the future, picking up patients in the earliest stages of insulin resistance. You see the lipoproteins that we pointed out on the very first page of the report, looking at the lower ApoA1, the lower HDLP, and the HDL2B, and the increased level of ApoB to ApoA1 ratio. Those were factors of lipid changes that correlate with insulin resistance. Turns out it takes about 1.5 years to begin seeing most of those lipoprotein changes of insulin resistance. If you're looking at this alpha hydroxybutyrate and oleic acid, those 2 biomarkers show up very early in the areas of insulin resistance, and thus when a patient is just becoming insulin resistant, even a few weeks or a few months, you're going to see it right here, and thus when your treatment is becoming effective, they're going to be the first to turn off. First to turn on, first to turn off, alpha hydroxybutyrate and oleic acid. Thus, these are going to be major biomarkers to help you in your patient care. Lastly, looking at this pancreatic beta cell function by measurement of the fasting insulin level or the proinsulin to C-peptide ratio. Turns out if I've got a patient on 2 oral drugs, or maybe an oral drug like Actos and a GLP-1 analog like Bydureon or Victoza, Tanzium, I see a patient with a fasting insulin level greater than 20, I'm going to put that patient on basal insulin. And the reason for that is I want to actually reduce the workload of the pancreas and cut down the inflammation. You see, I don't believe it's the blood sugar that's hurting anybody in diabetes. I believe it's the inflammation related to this blood sugar. And thus, if you look at this fasting insulin level elevated, or even a more sensitive factor of the pro-insulin to C-peptide ratio, giving those measurements, if they're elevated, using basal insulin in an early stage is very helpful, because your pancreas is going to be making 20 secretions per hour in a normal pancreas to keep glucose homeostasis. But when you give a person 1 shot of basal insulin, you're basically taking away the pancreas' need to make those 20 secretions per hour. Now the pancreas, with the basal insulin given to them by injection, only has to make insulin when the patient is eating or drinking carbs and requiring a bolus after that. Thus, the pancreas that has to do the 20 secretions an hour and the bolus is having to work harder than the pancreas that's only doing the bolus with feedings and carb intake from drinks. Thus, I encourage you to consider earlier use of basal analog insulin when a patient has 2 oral medicines, or an oral and a GLP-1 analog, and their fasting insulin levels elevated. It does not matter what their hemoglobin A1C is. Consider adding the basal analog insulin to lower the pancreatic inflammatory state. We've talked about type 2 diabetes, but I want to make sure we're understanding all the facets. It originates with insulin resistance. It has a beta cell component that ties in with beta cells that are burning out from just strict overload. If you and I were to work 24 hours a day, 7 days a week, we would burn out because we need rest. A pancreas usually would be done making insulin within 2 to 3 hours after a meal. But these patients with beta cell burnout sometimes have fasting insulin levels that are above 20, even 20 hours after they stop eating. Thus, a crazy amount of work overload. You're giving these patients basal analog insulin can take away that beta cell burnout and make such a difference in these patients. I used to use fasting insulin level above 20 as my key marker, but now seeing the proinsulin to C-peptide ratio above 5 is also a very significant place to watch. We talked about the water leak earlier, and when you have a water leak, why would you not want to turn the water source off before you go clean up the mess? Diabetes type 2 has a genetic expression. Why would you want to treat diabetes type 2 and neglect to turn off the genetic source if it was within your capabilities? Well, it is within your capabilities because Actos or pioglitazone goes into the nuclei and downregulates this response. So certainly you could make a major difference if you were using pioglitazone as a first-line drug. I personally believe pioglitazone is a better first-line drug than metformin. In days of old, there was a big price difference because pioglitazone used to be expensive, but now it no longer is as expensive. Used to be fear that there was a high risk of bladder cancer for unusual reasons from pioglitazone. The risk of bladder cancer for pioglitazone seems to be of a no issue at this particular juncture. And thus, I would encourage you to consider maybe switching your method of treating with pioglitazone as a first-line drug, GLP-1 analog, second-line drug. Third-line drug should probably be a basal insulin. Thus, turning off the genetic expression with the pioglitazone, rebuilding the beta cells with the GLP-1 analog, or maybe a DPP-4, and taking the pancreatic inflammation down aggressively with the basal analog insulin. The Actos, while downregulating the genetic expression in these nuclei, various cells of insulin resistance, would also be improving the adiponectin and the leptin situation tied in with the fat cells. Ultimately, you're going to have to treat the inflammation with diabetes, and to do that, you need to be looking at these markers. Now, we've already talked about myeloperoxidase, plaque 2, HSCRP, and fibrinogen. we've indirectly talked about flipping the switch in the liver when you overeat carbs and seeing that through the small dense LDL. The pancreas inflammation we discussed just recently about an elevation of fasting insulin level above 20 or the elevation of the proinsulin to C-peptide ratio above 5. The leptin to BMI ratio being a marker of brain inflammatory response, usually being thought of as insulin resistance of the brain or type 3 diabetes issues. Fat cell inflammatory response being the adiponectin. And there's a key point to be made with adiponectin. Adiponectin, when a patient is doing well with carbohydrates, will usually always go above 45 when the patient is consistent. When the patient is overeating carbs of a significant degree and creating a rather big inflammatory response, the adiponectin level will go below 16. When you see the adiponectin level go below 8, you have an extremely bad fat cell inflammatory response. And thus, if you think of all the fat cells that are within the belly, that is a big, big deal. Kidney function, I personally believe everyone should be doing cystatin C so we can pick up that estimated GFR of significance in stage 2 chronic kidney disease. It turns out if you're using measurements using the BUN, creatinine, albumin through the various schemes of measuring estimated GFR, that you're not going to get the accurate readings in stage 2 of chronic kidney disease, but you will with stage 3. But I think it's too late to be picking up on chronic kidney disease in stage 3. Thus, in my opinion, the cystatin C is a favorable test. In summary, if you're doing advanced diabetes testing, you can use an advanced panel to assess when a person has adequate blood sugar control. When they have insulin resistance, you can identify them early. When your treatment is working, you can identify when the insulin resistance is being turned off. You can also assess the third area of pancreatic beta cell burnout and if your treatment is effectively working to improve insulin production and pancreatic decrease in inflammation. I personally believe the doctor that has this panel versus a doctor who doesn't have this panel, or the doctor who has it is going to do so much better. And I would encourage you all to be doing this in your routine testing in every physical exam and in every patient thereafter who's identified as a person with insulin resistance, at least on a 3-month interval. Let's talk about treatments of some of these things. If you look at the ADA versus the ACE standards for prediabetes treatment, they're looking at hemoglobin A1Cs of less than 6.5, consideration of diet and exercise, watching the lipids, hypertension, obesity issues, and maybe the consideration now of using medication, because the American Academy of Clinical Endocrinology has recently put out a position statement that says you should treat prediabetes exactly the way you treat diabetes. I've been saying this for years. If a disease state is bad enough to kill a person, it is definitely bad enough to allow for treatment with medication. For years, we have been just suggesting you do diet and exercise, and that would be adequate for prediabetes. I've said, no. 35% of our patients that show up in the United States emergency rooms with heart attacks are pre-diabetics. Pre-diabetics have all the same problems with small vessel disease and large vessel disease that diabetics have. Why would we not treat these people aggressively with both diet, exercise, and medication? It makes no sense. American Diabetes Association and ACE guidelines suggest various places of control, 6.5% or 7%. Limit of carbs, some structure to saturated fat. There used to be an allowance for a fairly high level of carbohydrates through the American Diabetes Association, but their recent guidelines suggest being more careful in that area. In fact, there's a position statement they make that there's a growing amount of evidence that suggests that reducing carbohydrates in your diets will reduce cardiovascular events. If the patient truly has diabetes, there should be some monitoring of LDL. In my opinion, the LDL-P, they describe LDL-C, but looking at their lipids and making a difference in these areas, statin management should be considered.